easy. Now, okay, so setting up the fibula. For the sake of Daniel, we're not going to undress him entirely, but I will expose the leg. Tourniquet will be placed above the right leg. This needs to be placed prior to sterile draping in the ideal world, unless you're using a sterile tourniquet, of which exists as well. Positioning for the patient will definitively have the leg flexed, ankle, can you move down the plate slightly? Ankle flexed as well, with an intention of having internal rotation. If the individual has no arthritic problems, it's satisfactory to use a pillow or cushion or something soft on the inside, but it must be soft. If not soft, gel pads on all pressure points. So internal rotation of the hip. If the individual has hip problems, the best solution is equivalent to a sandbag or gel under the hip, as it may have a fixed flexion or fixed extension in the hip itself. Okay, playing the tourniquet. If you're not doing a combined flap such as ALT, you want to have this tourniquet as high as possible, placed with reasonable tension on your straps, connected to your machine, which you would have checked that it works, and put your additional secure straps round. This additional secure strap should not be too tight, as if it is too tight and the entire tourniquet is tight, when you reduce the tourniquet pressure you will still have a tourniquet effect, so that must not be too tight, finger loose. Tourniquet pressure for fibulas can be anything from 300 to 350, there's a variation. Tourniquet time is usually about 2 hours.
And just a comment about the foot plate, Brian, please.
So the reason for the foot plate, once again, it has to be a soft surface and or gel because of pressure points, allows to extend your perineal tendons, which will allow you in terms of getting into the right plane, particularly for raising a skin paddle. The reason for having the internal rotation is the position of your surgeons and assistant will have better direct vision initially to look for perforators when looking for your correct tissue, a plane between the perineals, but also, more importantly, it's extended and rotated away from you. When doing the back cut, which is essential in terms of the perforators, when raising the bed, you have more direct vision. If externally rotated, that's quite hard in that position. Some will remove the foot plate later on during the procedure to allow for that approach. But in our practice, most of us will have the foot plate holding that in place, extending your tendons so that they're visible and you get into the right plane, and they internally rotated to allow for you to get to your perforators visually at that angle, and then also dissection from behind.
Perfect, thank you.